What if one of the most celebrated effects of GLP-1 medications is actually masking something deeper? Welcome back to the Exam Room Nutrition Podcast. I'm your host, Colleen Sloan. I'm a PA and dietitian, and today's conversation is one I think a lot of us in clinical practice are quietly wrestling with. We're prescribing or at least discussing GLP-1s more than ever. We're seeing weight loss. We're seeing outcomes that look successful on paper. But I've been wondering lately, are we asking the right questions before we start? Are we missing underlying eating disorders that don't look like what we were taught in school? And how do we know when success might actually be reinforcing something harmful? In this episode, we're going beyond weight, BMI, and food noise, and really unpacking what's happening underneath the surface when patients lose weight on a GLP-1. To guide us through this conversation, I'm joined by Shawna Melbourn. She's a registered dietitian with over 20 years of experience in eating disorder care. She's a certified intuitive eating counselor and an approved supervisor through the International Association for Eating Disorder Professionals. And she has trained countless clinicians on how to bring a more compassionate, evidence-based approach to this work. So in this episode, we're talking about why appetite suppression isn't always a win, the subtle but critical red flags clinicians should be screening for, and Shawna gives us 3 simple, powerful questions to use to uncover what's really going on with your patient's relationship with food. This is a really nuanced, sometimes uncomfortable conversation, but it's one every clinician should have with their patients prior to or during treatment with obesity medications. So get comfy or drive safe and enjoy my conversation with Shawna. Shawna, thank you so much for the gift of your time and sharing your wisdom with us. Welcome to the podcast.
Thank you so much, Colleen, for having me here. I'm really looking forward to getting into this conversation.
So from your perspective in the eating disorder space, what concerns do you have right now with the influx of GLP-1 medications?
Yeah, so I think clinically what concerns me the most, or one of the many concerns that I have, is around the appetite suppression and around the weight loss itself. I'll start with the appetite suppression because that reinforces restriction. And restriction is one of a very common symptom of many eating disorder experiences. Now, when we think of eating disorders and how they exist in individuals, it exists in all shapes and body sizes. In fact, most people live in a straight size body or a larger size body with also anorexia nervosa. And this isn't what we traditionally assume with the diagnosis of anorexia. As we often imagine somebody living in an emaciated body, or that a certain body weight, shape, and size is associated with a certain eating disorder diagnosis. And what concerns the eating disorder care community is that so many people are being put on GLP-1s or suggested to start GLP-1s, and they haven't even been screened for an eating disorder or a history of an eating disorder or living with the chronic backlash of dieting or body image disturbances. There's so many reasons why people develop an eating disorder. It isn't just one reason. But overarching, what we usually see is that satisfaction of that drive for thinness. And what I mean by that is dieting, losing weight. This is really the number one reason why people end up developing an eating disorder or go on and develop disordered eating. And what looks like quote unquote successful weight loss can actually strengthen the eating disorder voice. I'll go off on a bit of a tangent here because I just want to explain what the eating disorder voice is and why I use that terminology. We think of the eating disorder as though it's like the third person in the room. It helps to lift the blame and shame from some people. And so that's why we talk about it as though it's like, the third person. So it can really strengthen that eating disorder voice or that drive for thinness. GI side effects can mask things like malnutrition. Malnutrition can show up in all eating disorder presentations. The nutrition rehabilitation that we work so hard on can become much, much harder and much, much greater in those who are living with an eating disorder as well as taking GLP medications.
All right. So you had mentioned the reduced appetite, and this is sort of what is celebrated so heavily as a positive side effect of GLP-1s. It is really why they work. They quiet food noise. And so why is this not automatically a positive outcome from an eating disorder perspective?
So, quieting food thoughts is not the same as healing the relationship with food. We want to be really clear on that. And another important piece is that GLP-1s don't treat trauma, emotional regulation, impaired hunger cues, anxiety around food, or body image distress. They may suppress symptoms, but eating disorder recovery is about addressing the root causes. And this is the exact thing that GLP-1s turn our focus away from. So the message about quote unquote quieting food noise has become something that we need to fix rather than understand and sit with and get closer to. There is no consensus of what food noise actually is. There is no definition of it. And when we dive into the research of what interrupts the relationship with food, it can be things like trauma, food restriction, chronic dieting, food and body image trauma, as well as pathologizing food noise. This is causing us to look beyond the root causes of things like fear or discomfort of hunger, fullness, or food thoughts.
Okay, so you mentioned that clinicians are often not screening patients prior to putting them on a GLP-1 for eating disorder or disordered eating habits. And so I'm curious as to what things like a patient history or certain behaviors should raise a red flag for eating disorder risk for a clinician before they even start a patient on GLP-1 therapy.
Eating disorders, firstly, can be so tricky to detect and address and assess. They often hide in plain sight because so many people hide in deep pain and deep shame. So to me, it makes sense that not all clinicians, even if you are really well skilled in eating disorder assessment, you may not even pick it up again because of that need to hide. So the number one reason why people develop an eating disorder is due to satisfying their drive for thinness. So again, the crux of so many eating disorder experiences. So if a person who has had a history of restriction or any kind of eating disorder, this would raise a really big red flag for me.
So I would love to hear just kind of quick and easy screening tools or things that you would love a clinician to screen or how they should screen for an eating disorder.
There are three questions that I like to lean into. Number one is, how much time do you currently spend thinking about food? This isn't a leading question. It's very open-ended, and we can get into a bit of a conversation that may not, unravel into like an hour conversation about something. Because if somebody says, yeah, I think about food 20 hours a day or 10 hours in a day, I can't stop thinking about food. Oh, well, why is that? Maybe we dig a little deeper to understand if there's maybe some food restriction currently going on. Maybe there's a history of food trauma that was going on. Or maybe that person says, well, I don't think about food and I wish I never had to think about food. I wish I could just take a pill and never have to eat again. That also tells us a lot about the person's experience with food. The second question is, if there was one thing that you could change about the way that you eat or the way that you exist in your skin, what would that be? Yeah, non-assumptive that the person wants to change something. We're just asking just a general question, could there be something that you would want to change? And what would that be? Well, I want to lose X number of pounds, or I want to stay the exact same, and yet they're very malnourished and not eating enough food, right? So there's a lot that question can provide us. The third question is, when you eat food, do you eat food differently when you're with other people compared to when you're by yourself? So there's a lot of information that could come from this question. The person might answer, yeah, when I'm with other people, I eat like a bird, but when I'm at home by myself, I just can't stop eating. That tells us a lot. Most likely there's a considerable amount of shame when this person is eating food by themselves versus with other people, and vice versa. Or the person says, yeah, I pretend to eat a lot when I'm with other people, but when I'm by myself, I just want to avoid food altogether. So again, these questions can really dig up a lot without spending hours and hours and digging into that person's history.
Yeah, I love those. Honestly, even if you pick one or two, if that's all the time you have, it's a great way to screen and say, hey, you know what? It sounds like there's something deeper here or more here. Here's your referral for a dietitian who can really help you work through these things just to make sure that you're set up. We've got the best support for you before we go through with this journey. I think that could be a great conversation opener and a way that you can make a referral to then pass the baton to someone who is more experienced or maybe has the expertise in that area. Okay, so from your perspective, for a patient with a history of an eating disorder, do you think a GLP-1 is ever appropriate, or is this something that is always a contraindication?
That is such a great question. And I'm really glad that you asked that because we don't even know yet, to be honest. We have very little evidence that is showing that GLPs could support the reduction of binging. And anecdotally, I've actually seen this as well. Now, mind you, when I see it in my practice, this person is being supported with a multi-D team who is very well eating disorder informed. But I don't think we are there yet to conclusively say whether or not GLPs are appropriate or not for people living with an eating disorder. My hope is that a multi-D approach would be considered best practices overall to determine whether or not a GLP could be appropriate for an individual and really take it on an individual basis. The research itself is not the only thing that we rely on to determine whether or not a GLP are safe to use in the eating disorder population, right? An evidence-based approach includes the research, but it also includes the clinician's experience and, of course, the patient's values and experiences. And so when we take an evidence-based approach, again, I think it really centers the individual with that is when we're trying to determine whether or not a GLP could be appropriate. And really, my stance isn't anti-medication. It's really, I'm really about pro-screening and individualized care and making sure that that person has wraparound support, again, in this ideal world that I'm dreaming of.
Yeah. I think that's helpful. And there's so much that's new about these medications that we don't know yet. And we are all trying to figure it out as we go. I would say, we do have some evidence, but with every new medication, every new study, every new year that passes, we do learn new things. So, in 5 years, we'll know a little bit more. So now what about for the patient who's on a GLP-1? They have had a successful weight loss. They've got great outcomes. But what clinical signs for you as an eating disorder dietitian kind of tell you that this medication, although successful in terms of weight loss and achieving thinness, is worsening eating disordered behaviors?
We look for is the intensity and the frequency of symptoms and how these symptoms and use the word symptom, I'm really referring to restriction, self-induced vomiting, or other types of purging behaviors, binging, or any other type of symptom that relates to the existence of the eating disorder. And so if somebody is uh, on a GLP-1, we see them lose weight and we think it's quote unquote successful. And then, we send them to an eating disorder provider, maybe for a checkup or maybe to check in their nutritional adequacy, what it might be. But then we start to see these red flags. And the things that cause the red flags to go up in my mind, again, is the intensity and the frequency and how much these eating disorder symptoms and behaviors and thoughts impact that individual's lives. So when I see somebody who is avoiding food groups, unable to feed themselves if they go out of their house, if they're afraid of eating food that other people made, or they're not able to go to restaurants, or they're not able to do certain things that they usually would. Maybe there's an impact on mood. We know that malnutrition impacts things like anxiety and depression. So if we see worsening of these mental health conditions, then yeah, that also warrants some investigation for sure. Things like malnutrition, doing a malnutrition screening tool, because what we do know is that once malnutrition starts to set in, eating disorder thoughts and behaviors start to spiral out of control. We have lots of evidence that supports this from the Ansel Keys study and how, during that time, how the men that were involved in the study, they started to obsessively behave and think around food and start to develop odd behaviors that weren't originally there before they became malnourished within the study. So we know that malnourishment, it really kicks things up quite a number of notches in terms of the intensity. But I really focus in on things like the anxiety around food, the anxiety around food and body, the deep fears that come around food and body image as well. So these things are really raise the big red flags in my mind.
So we track weight, we track BMI frequently for patients on a GLP-1 because that is really what we're monitoring. But what else should clinicians be monitoring to assess specifically the safety and the nutritional adequacy of the diet of that patient?
Right. Yeah. So I think what we need to look for overall is the amount of nutrition that that human is able to consume. Because if somebody, and I'm not going to go into numbers here, but if somebody is eating a certain amount of food prior to GLPs, and then the amount that they're eating is not meeting their nutritional needs, that goes above BMI and weight because a person's weight may or may not change, but the amount of food that they are consuming can plummet dramatically. And once that sets in, then we get into things like malnutrition, nutritional inadequacy, undernourishment, things like this. And this is where we start to see our clients get into trouble with things like hair loss, severely dry skin, mood changes, intensity of anxiety and depression, etc. They may be experiencing other side effects of malnutrition, but it can be masked by the satisfaction of the drive for thinness. So it can be masked physically, but it can also be masked emotionally as well. And so if we're just tracking things like weight and BMI and using that as our quote unquote success markers, we would be missing out on such important context of what is actually going on underneath that. Because weight loss or tracking weight, tracking BMI, these are just numbers. This does not capture the gravity of the mental health changes that we can see in a person. It doesn't track the isolation. It doesn't track the intensity of traumatic experiences that could be popping up as the person loses weight. It doesn't track nutritional deficiencies. And these are the things that are being missed out on when GLPs are initiated and when we are just tracking these numbers. So we need to go above and beyond just these numbers and really take a much more wraparound and holistic approach to caring for an individual as they are losing weight.
Yeah. I like that perspective a lot. And, a lot of patients are already coming in with a lot of shame and blame and guilt. And so I want to kind of round out our conversation with some language that you've maybe heard clinicians say or seen online, or maybe your patients told you that they were told such a thing. What is that language that we should be avoiding because maybe it's unintentionally reinforcing that restriction or the shame, or maybe even it's reinforcing disordered eating among our patients?
Plotting weight loss will can cause harm in so many situations. If you aren't really clear on the person's history of living with an eating disorder, disordered eating, you could unintentionally be applauding the existence of the eating disorder. And that is what causes harm. So if we are tracking weight, applauding weight, congratulating that person on shrinking their body, number one, we are perpetuating this harmful belief that large bodies need fixing and that small bodies are somehow inherently better. Number two is that we could be perpetuating that intensity of somebody's eating disorder. So one of the things that we could steer our brains towards is asking questions like, what is this like for you? What has this journey been like for you? What has come up for you since starting the GLPs? Even asking the question before GLPs are even brought into the exam room is, what would it be like for you if we did talk about GLPs? What kinds of things would come up for you? What does it feel like for you when you see other people using GLPs? Just inviting some more conversation around it that decreases harm. Not assuming that when a person shows up in the exam room living in a larger body, do they want to even be on a GLP-1? And they could actually be sitting there feeling extremely terrified of the provider bringing up GLPs in the first place. So, inviting conversations before we assume that a GLP is the right direction for us to go.
I recently had a clinical psychologist on the podcast, and it was actually in episode 140 called Obesity Care Through a Mental Health Lens. And so this would be a great episode for you guys to go listen to after this one, because we really unpacked kind of this whole philosophy of just because a patient is coming in to see you doesn't mean they want to talk to you about their weight or to lose weight. And she had even made a point that they might even be in this different mindset from when they scheduled the appointment, even if it is a quote weight loss appointment, right? 3 weeks ago, they were really gung ho and wanted to come in and talk to you about starting a GLP-1, but maybe last night, this morning, they're not feeling it. And so we can never make that assumption. So that's why I really love those questions, to being curious and asking the patient how they feel or what's been coming up for you in this subject, rather than just making those assumptions. So I'll link down to that episode. It's 140. Take a listen to that one after this episode. Now, you gave us some really good suggestions for some neutral, safe language. Is there anything else that you think clinicians should say when discussing appetite changes or eating patterns with our patients?
I think one of the things that clinicians could take on is a more nuanced approach when assuming that appetite suppression is a helpful side effect. Not everybody who is taking a GLP feels that this is a positive side effect. It can cause quite a bit of fear. It can cause quite a bit of discomfort. It can be quite triggering to past traumatic events. It can really shift a person's mood, anxiety, depression. Missing out on or not being attuned to one's hunger and fullness isn't necessarily a quote unquote positive thing. It can bring up quite a bit in a lot of what I'm seeing in my practice and a lot of the people that I'm working with. It can bring up body image distress as well. So we can't just assume that losing weight is always going to be a positive thing. In fact, some people, they do experience quite a bit of body image distress as they lose weight. So, and the chaos that it can create when somebody doesn't feel attuned to their hunger and fullness. Some people, yes, they do find this really positive and they're very thankful for that side effect. And yet for other people, it can cause quite a bit of distress. So just being mindful that not everybody is going to experience GLPs on the same level, and that there are many, many different experiences that I think that we can consider when somebody's taking these kind of medications.
This is such a sensitive, challenging topic that hopefully, in years to come, there'll be more training for clinicians so we can really learn how to have these conversations and be a safe place for our patients. So I'm just so grateful that you've carved out the 30 minutes to just share your wisdom with us, really from an eating disorder lens. So thank you so much, Shawna, for just answering all my questions and helping us navigate this. If people want to hang out with you online, where would we direct them?
Yeah, thanks so much, Colleen. I'm really glad that we had the chance to talk about this as well. It is nuanced and it is very sensitive. And I just want to make it clear that, again, I'm not anti-medication. There can be some really positive stories out there. I've heard them. I have worked alongside people that have had some really beautiful experiences with them. And yet I've also worked alongside people that have had some very traumatic experiences with it. So finding the nuance, finding that very delicate time to talk about it, I really appreciate this. So thank you. So if anybody does want to find me online, I have two ways that people can find me. One is with my private practice. So that's Shawna Melbourn, registereddietitian.com. So that's for that website. But I also do online training for dietitians and other healthcare providers who want to deepen their learning and understanding and education around eating disorders. So I run a few online platforms. It's called ED for RDs, Eating Disorder Education for Registered Dietitians, and it's edforrds.com. And you can also find me on Instagram and LinkedIn and Facebook. And I think I've just about covered all the places where people can find me.
So many ways to connect with you and learn from you. So if you're a dietitian or a PA, even interested in eating disorders, I'm sure her groups would be really a wealth of information for you. Don't forget to check the show notes for all of those resources, plus related episodes that I believe you will love to listen to after this one. Shawna, thank you so much for being here. I appreciate the gift of your time.
Thank you so much, Colleen.